Okay, I think we'll get started now. Good morning, everyone. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thanks for joining us today for our second webinar of the Winter SRS webinar series. Held every Thursday between now and May 6th, this new series does include 11 talks over 11 weeks. So if you haven't already, I do encourage everyone to visit srswebinars.com to take a look at not only the upcoming presentations, but you can also register to view recordings of prior webinars as well. And one final item of business before we get started. If you'd like to submit typewritten questions at any time during today's talk, you can do so by using the Q&A button found at the bottom of the Zoom console. And time permitting, your questions will be addressed at the end of today's presentation. So without further delay, I would like to introduce today's moderator, Dr. Igor Barani. Dr. Barani is the chair of the Department of Radiation Oncology at Barrow Neurological Institute in Phoenix, Arizona. At Barrow, Dr. Barani specializes in the treatment of brain and spine tumors and in the applications of radiosurgery and stereotactic body radiotherapy. Dr. Barani, I'll hand it over to you.
Thank you, Mark. Good morning. It is my pleasure to welcome our today's speaker, Arjun. Arjun is an international clinical research leader in the field of high-precision stereotactic radiation to the brain and spine for both brain metastases and primary tumors. He trained at the University of Toronto in radiation oncology and completed radiosurgery fellowship at UCSF, and that's where Arjun and I actually met for the first time. He's published over 500 peer-reviewed papers in high-impact journals, and wears many hats, including leading the Sunnybrook Odette CNS Neuro-Oncology program. He's a deputy chief of Department of Radiation Oncology at Sunnybrook and a director of the Sunnybrook Center for Ablation Therapy program, and is involved in the installation and groundbreaking work related to applications of MR-guided treatments, as well as MR-guided focused ultrasound in combination with radiation therapy. He has published extensively on various spine and radiosurgical issues relevant to daily practice. And it is my pleasure to welcome Arjun today. And welcome, Arjun, and it's good to hear you finally after a few years.
That's great. Thanks, Igor. So I'm going to start sharing my screen and then present. Okay, so that should be fine. If there's any issues, please let me know. But it is a great pleasure to speak to you today on fractionated radiosurgery. And I've titled this Fractionated Radiosurgery is the Future. Just my disclosures. So in the last 10 years, there's been a major change, and certainly in some countries it's already happened, in others it was evolving, but ultimately the use of whole brain radiation has really been replaced by radiosurgery. And it's been an excellent development for patients to ensure that we maximize their chance for preserving neurocognition. Now, it arose as a result of several years and several randomized trials. I often say this is one of the only areas where we've needed so many repetitive studies to prove the same thing, that radiosurgery certainly does offer excellent local control. The distant brain control is higher as a result of radiosurgery because you're not treating the whole brain, but it's still about a 50% risk of distant brain failure as opposed to 30% with whole brain radiation, and survival is not impacted. Most notably, there are randomized studies looking at neurocognition that proved the adverse effect of whole brain radiation. And I do note that these are mixed histology studies, and the Australian study that actually looked at melanoma only failed to even show a distant brain failure relapse rate with the advent of whole brain radiation. So although we have these rules of thumb, they are changing, we're learning more, but for 1 to 4 brain mets, radiosurgery is really the standard. Now, the principles of radiosurgery dosing are really to dose de-escalate as the tumor diameter increases. And that's really something that's counterintuitive, but it's there for safety in order to respect the risk of radiation necrosis. And this is just the phase 1 data from Shaw, but sometimes with these very irregular tumors, in particular surgical cavities, you may be treating these patients with a subtherapeutic dose at 15 gray, potentially for no reason as a result of the development of hypofractionated radiosurgery. Now, if we look at some of the early data that was looking at outcomes for a single fraction, as we dose de-escalated, the rates of local failure increase. And this initial work from many years ago concluded that for tumors that are 2 centimeters or greater, they're not being controlled as much because your dose de-escalating. If you could give that 24 gray in a single fraction or 20 gray, even to large tumors, you may still maximize local control. However, the risk of radiation necrosis is paramount. Now, when you look at the association between various hypofractionated regimens, and we're really talking about 2 to 5 fraction types of treatments, most typically 3 or 5 fractions, and you look at the ratio or the relationship between tumor control and normal tissue, even if you're talking about a dose of 14 gray or 15 gray to respect a rate of radiation necrosis, you can really escalate the dose to the tumor by hypofractionating. Now, early work from Minetti really showed this concept that multifraction radiosurgery, typically 3 fractions, can not only increase local control, but reduce the risk of radiation necrosis. And this is the theory that's been culminating. We do not have randomized data as yet, but that is in development. But at the end of the day, this is actually really right on and one of the early leaders in the concept of hypofractionated radiosurgery. So when I started many years ago now, and I came in from San Francisco, where I knew Igor and the team there and learned stereotactic radiosurgery for the brain, I was approached with a patient like this who was treated with whole brain radiation for this big metastases, and it's breast cancer. And they said, oh, it's too big for radiosurgery. And 6 months later, even though this was the only site of disease, it was progressing. She was in palliative care. So they asked me to take a look. I was here fresh from training, and I said, yeah, sure, we can hypofractionate this. Why wouldn't we? And we did, and we gave her, in this situation, 35 gray and 5, which I typically don't do now as a result of necrosis. I mainly give 30 or 32.5 and 5 when I can. And ultimately, we've shown an excellent response in this patient. She actually had 2.5 years at home, back with her children. And we've reported some of our early data, which are in the process of being submitted, looking at seeing high rates of local control at about 80%, with a symptomatic necrosis rate probably around 8%. And these are data that are very consistent with the literature that's evolving. Now, if you look at some of the data for toxicity, if you did do that single fraction radiosurgery for these large brain tumors, some of the data has shown unacceptable radiation-related toxicity. So you're really increasing that rate of radiation necrosis, and it can be life-threatening. So why fractionate? So this is really the advent of frameless systems, the ability to deliver stereotactic precision and deliver 2 to 5 fractions of radiation as opposed to 1. Well, the pros are that it's safer on the normal tissues due to repair. There's technical safety as fractionation blurs dosimetric uncertainties. It may be more effective due to reoxygenation and redistribution between fractions, but moreover, you can safely escalate the total dose to achieve an equivalent dose of a high-dose single fraction radiosurgery. Now, the cons that are discussed are that you may be inducing or not controlling for tumor repopulation and repair between fractions. That's not really an issue when you're dealing with a few fractions. That's more a dogma associated with more protracted fractionation schemes and cancers like head and neck cancers. We're talking about 7 weeks versus 9 weeks. It's not really relevant in this paradigm. There may be changes in tumor dimensions between fractions, and that is interesting. And this is why we've been looking at some MR-based monitoring in hypofractionated radiosurgery. We may not be maximizing new biologic effects inherent to high-dose per fraction single fraction radiosurgery, and I'm still not sure about this. I think as long as you're dealing with a high enough dose of more than 5 gray or more, but a heterogeneous dose distribution, you're probably getting those effects regardless. Now, how do you dose and what do you give? Well, the majority of patients are treated with either 3 or 5 fractions. This is some interesting dose data from Korea that looked at 8 gray times 3 versus 9 gray times 3 versus 10 gray times 3, and really looked at and a similar idea in terms of a phase 1 escalation study, and showed that 10 gray times 3 is really quite toxic. 8 versus 9 are about the same, but you do get some better potentially tumor control with the use of a 9 gray times 3 versus 8 gray times 3 while still respecting radiation necrosis rate. I mean, this is particular to the gamma knife technology. Now, we looked at our data, which was 5-fraction radiosurgery using a standard LINAC and standard techniques of cone beam CT image guidance. And we looked at our adverse radiation effect rate, both for symptomatic and non-symptomatic ARE. And this is just a symptomatic data showing that we do see elevated rates. These tend to be very large volumes, not only in cavities, but in intact tumors. And what you can see here is that the intact tumor ARE rate was actually higher than the cavities. And this leads us to the idea of what is the pathogenesis of ARE. And it's probably a combination of not only normal tissue dose, but also the interplay of the effects of release of, say, cytokines or cellular damage within the tumor itself. And we've always felt like this, but this is a little bit of data to promote that idea. But when we looked at our dosimetric analysis, it was really the volume of normal brain minus the intact volume GTV. And the relationship really came out in the intacts, not the cavity yet, that we use a threshold of 10.5 cc's, and that guides us in the dosing. So if we can get 30 or 32.5 gray in 5 while respecting the BMC 30, we'll do it. If it's not, we start to reduce to, say, 27.5 in 5. Now, there are high-tech data now giving you a broader sense of dosimetric guidance for hypofractionated radiosurgery, and there really is not a lot of data. So this is a very important paper, and it gives you some sense, like we did have many years ago for single fraction radiosurgery with the V10 or V12 gray. Now you have some data to help guide your dosing and better understanding of dosimetric parameters to guide safe practice with this report as well. Now let's talk a little bit about cavity radiosurgery, because there's a lot of variability for intacts, but I certainly do believe in hypofractionated radiosurgery for cavities, and I actually never give single fraction radiosurgery in this indication. So here's a patient, pre-op CT, big enhancing tumor, was taken to the operating room, and now you're left with this postoperative cavity. Now back in the day, we'd give whole brain radiation, and now we understand that radiosurgery certainly is an excellent alternative to whole brain radiation and spares the neurocognition. But the issue is, do we give single fraction or do we hyperfractionate? And why do I hyperfractionate? Because these volumes tend to be large, irregular, and I certainly do worry a lot more about the normal brain tissue dose when you have irregular contours that tend to be somewhat large. So again, those concepts or advantage of a hypofractionation really do play out here in surgical cavities, potentially even more than intact tumors. Now, if you look at our data, and these are data from my group where we published on 5 daily fractions of cavity radiation, typically giving 30 gray in 5 fractions, we're seeing very high rates of local control, reasonable symptomatic necrosis rates. And again, this is done on a simple linear accelerator with a cone beam CT image guidance or robotic hexapod top, but immobilization in a simple mask and a 2mm PTV. Now, if you look at the data, and now we do have randomized studies, the main one from Paul Brown comparing to whole brain, it concludes, as we knew before, that whole brain radiation does cause neurocognition, even in the postoperative patient. Now, what was important in this study was the local control rate, because if you look at the surgical bed control rate, you saw 60% versus 80%, and this really caused us concern. And one of the reasons why we may be seeing this is because we're dealing with de-escalated single fraction radiosurgery. And in these low single fraction radiosurgery doses, the actual biologic equivalent dose would be even lower sometimes than 30 gray in 10. So the whole brain radiation control rate was really quite consistent, but we were alarmed at the radiosurgery control rate. Now, what we learned from the MD Anderson study, which looked at observation versus radiosurgery, was that there are so many factors playing into this. And one is the preoperative diameter. And if your preoperative diameter is larger, your local control rate suffers. Again, this was single fraction radiosurgery. But overall, there is a benefit to radiosurgery in terms of local control as compared to observation. And we do have some data here relating the local control rate to the preoperative diameter. So you may say, well, I'm going to use single fraction radiosurgery for preoperative diameter tumors less than 2.5 centimeters, but for the larger ones, I'm going to use cavity radiation to try and prove that local control rate. And this is an area of further development and understanding. Now, what's interesting, this is not based on the postoperative cavity volume, it's based on the preoperative radiosurgery volume. And there's a lot of room and work to be done to understand that relationship further, as it really has not been elucidated sufficiently. Now, cavities are very challenging, and it's much more than intense than drawing an intact metastases. And this paper came out saying, oh, there's so many reasons why we saw these kind of marginal failures with cavity radiosurgery. And our argument was that one of the reasons was well, you may be not drawing it properly, and you're not taking that meningeal margin. And the authors acknowledged our comment to the editor, but this also prompted us to do a consensus contouring guideline exercise. So a bunch of us actually put our contours together in sample cases, and we saw quite a bit of variability in how we were drawing them. And there was a mixture of surgeons, radiation oncologists, gamma knife users, LINAC users, CyberKnife users, that we were able to kind of have a very nice mixture of approaches despite technology variations. And we came up with these rules in terms of cavity contouring. And there's a bit of validation from UCSF that suggested that if they actually implored these rules, in particular a 1 centimeter or 5 to 10 millimeter margin along the dura or marginal surfaces or meningeal margin, that they may have been able to avoid some of these local relapses. As you can see here, the relationship of the tumor relapse in pink with the isodose lines. And that's a bit of data to validate, and certainly we need more data, but it was encouraging that the contouring guidelines made sense. And the NCCN do endorse the contouring guidelines, but also hypofractionated radiosurgery. So what does it mean to the individual patient? Well, this is where we're getting into a lot of complexity. So here's a patient, and I showed you kind of the example before, where it had a big cerebellar met, CT only, had one other lesion, was taken to the operating room before an MRI, which sometimes can happen. And ultimately, the MRI is done, and now we see this. So we have a postoperative cavity. We have an intact lesion that may be about 1 centimeter to 1.5 centimeters, depending. And then we have a small little lesion over there. So how am I going to approach this patient? Well, first of all, I'm not going to give whole brain radiation. I'm going to give radiosurgery. And then the question is, how can I optimize the patient and take advantage of all these different technologies that we have? And some departments have dedicated units for brain radiosurgery in addition to their normal linear accelerator workflow. And we have been evolving our approach to take into account our own experience. So the cavity, I would give hypofractionated radiosurgery, and using flattening filter-free and VMAT techniques, this treatment's a few minutes. And then this other lesion, sizable enough that we could do it at the same time and we felt comfortable, and we would treat both. So patient easy, they come in, 5 minutes of treatment, and that's it. But for the small lesion, we never felt that it was appropriate to use hypofractionated radiosurgery for tumors under 1.5 centimeters if you're going to use a LINAC. And I would bring this patient, and at that time, we were doing frame-based radiosurgery and evolved to frameless radiosurgery, but using a linear accelerator with cones. And that's painful, and it can take 30 minutes even to deliver that, but it's a bigger ordeal for the department. And so the principle here is, think about each lesion individually. Don't just do single fraction radiosurgery to all three because you're going to do it anyway for the one. Use the technology to your advantage and maximize your ability to control all the tumors as best as possible. So why did I use the frame here or LINAC-based technology with a cone rather than simply doing MLC? Because the principle of single fraction radiosurgery is minimal to no margin. So in the past, again, we would do this with our linear accelerator. Now we have a gamma knife icon here, and we're dealing with frameless radiosurgery. And that really is the future. And this is why also radiosurgery has been able to be delivered in much greater capacity now across the world. Now, back to that lesion, that small little lesion, if I treat with the MLC LINAC, there are real issues associated with small field dosimetry. And essentially, you may not really realize that your measured versus planned dose is really quite different, and you could be overdosing some of these tumors. And moreover, you have to be aware of the positional issue or of the position of the isocenter to the lesion, because as that distance increases, and this is particularly relevant for multiple metastases treated with single isocentric techniques, you may miss at the more extreme ends of the distance or rotations from the actual planned isocenter. So we have a rule of 10 centimeters between lesions, and then we would use a second isocenter if we were doing LINAC-based radiosurgery or hypofractionated radiation. So another point to understand also is the dose distribution. And this is where we're learning a lot more in terms of, what some of the differences are between the technologies, which we have known historically with single fraction radiosurgery. It's just that when we started moving towards dedicated unit, like the Gamma Knife Icon, and we were doing hypofracture radiosurgery, we started really seeing these very high doses because we typically prescribe to the 50 to 60%, sometimes higher, but a lot of heterogeneity. And it made us a little bit worried in the beginning that we said, okay, well, let's keep our minimal peripheral dose to 25 and 5. But if I did that on a VMAT, it really is quite cold, and we felt comfortable with that MPD as a result of the heterogeneity. And we're not using margins, and these are hot plants. And it was just an understanding of it whereby these tumors are large. And does that matter? Because it probably doesn't matter for tumors that are small, but doesn't matter for tumors that are large. But it did cause us to kind of change our practice. Now, if we would have done our standard approach here on the LINAC with 32.5 and 5 with VMAT, this is what that dose distribution would look like because we use a 2 millimeter PTV. But what you see here is really still not a lot of heterogeneity in the dose distribution as compared to a 25 and 5 with our Icon technology. And just shows you, it doesn't matter, the technology is more about where you prescribe and also some of the technical attributes that lead to such heterogeneity. There's a little bit of data that got published in France that challenged that norm that we used to think that it didn't matter, if you prescribe to 50% or 70% versus 90% with a LINAC, because the data never really borne out. And the way that I'm approaching this now is to think that, the concept of heterogeneity really may not matter for small tumors, say a centimeter, where you could treat it whichever way you want, because they're small, they're going to respond. But these larger tumors, first of all, they're not going to necessarily have as good rates of local control because they're tumor. And this is where we may be able to prove such a hypothesis that the heterogeneity matters in the dose distribution. And what that may translate to is the ability to keep a minimal peripheral dose that's lower, potentially reducing the risk of radiation necrosis, but still getting the same, if not better, local control rate because you're blasting it in the middle and giving, and sometimes there's 60 to 70 gray even in the middle of a large tumor when you prescribe to 50% if you're talking about a 30 gray and 5 fraction treatment. So I think we're in a different paradigm. And I think that we really have to revisit this concept of heterogeneity and what it means for dose distributions, in particular for brain metastases. And this is an area that hopefully within the next year, I think we should be able to come out with some very provocative data based on our own experience. So I'm looking forward to that because I do believe in it. And I do think that it is a factor to consider. Now, one of the other areas that are very important, in my opinion, for hypofracture radiosurgery is salvaging radiosurgery failures. So as we're talking about more and more radiosurgery being delivered, we are also going to have to deal with the issue of how do we deal with progression? Because you're going to get it in maybe 10 to 20% of time. So one approach is to hit it again with radiosurgery, single fraction. And what we're learning is if you do that, you're inducing high rates of radiation necrosis, but moreover, and this interesting study, and it should be taken with a grain of salt as it's not controlled data. But if you do SRT or hypofractionated radiation as compared to repeat radiosurgery, your control rates may also be better. And this is the old adage that if it didn't work the first time, why is it going to work the second time if you just do the same thing again? But moreover, in this situation, you're not only going to not help the person in terms of tumor control, but you may actually hurt the patient too. And this is where we're seeing these elevated rates of radiosurgery if you use it again in a patient with prior SRS. So I think it's very important to understand this, but there have been limitations. And one such limitation is these small little tumors deep in the brain where you can't necessarily treat with an MLC in a sufficiently correct way to salvage. So the idea would be, okay, give it another SRS, single fraction. In the old days, put the frame on and do it. But you don't necessarily have to do this anymore. And some of this area was initially really challenged by CyberKnife. And this is certainly a credit to John and really forward thinking in terms of the concepts of hypofractionated radiosurgery in the brain and elsewhere with that device. And basically now with our device that we have here, I take a look at this small little guy. It grew. I mean, I don't need a biopsy to know that that's not radiation necrosis, but how am I going to treat it so small? Well, I'm going to hypofractionate, but I'm going to use now my technology and give the dose of, say, 25 gray and 5 fractions in this situation to salvage this area. And we want to keep those margins tight. If I use a 2 millimeter PTV and increase the volume irradiated and I necrose them, this is potentially neurologically disabling for the patient if they get significant radiation necrosis. And again, that risk is there. Another concept in terms of hypofractionation in a little bit of a different vein is staged radiosurgery. So this is an example of a patient that was operated on for this cerebellar peduncle lesion pushing the brainstem. I was really quite impressed with the surgery, and then had 25 gray and 5 fractions at an outside institution to the cavity, when lo and behold, there was growth again. So what are you going to do here? So now we've got an intricate area. You've got a critical organ at risk that can kill the patient if you cause significant necrosis, but I've got a tumor here that needs to be treated. And they've just had 25 gray and 5 fractions. So what am I going to do? Am I going to do single fraction? No. Do I want to give more daily hypofractionation? I could, and maybe think of an eight fraction regimen or not. However, we really like this idea of staged radiosurgery for these patients. And this is an idea that melds the worlds of hypofractionation with adaptive radiosurgery. So here, and this is really pioneered by several groups in Japan, the Cleveland Clinic, and I believe San Francisco had been doing this. But certainly I've been reserving this technique for patients in this difficult quandary. So I treat with 8 gray in 1, I give a 2-week gap, I re-image, hopefully I can shrink the volume, plan, treat, 2-week gap. And instead of giving, say, 8 gray times 3 fractions, because this is reirradiation, I drop the total dose by giving 4 gray on the last fraction and basically treat with an adaptive strategy again. And in this situation, this has worked out very beautifully for the patient. And now he's about 2.5 years out with no recurrence and no radiation necrosis. Now, this may not be ideal for somebody who needs to rush into their chemotherapy and delays aren't acceptable, and you want to do daily to get it through, or there's rapid progression. But in the person that you can do this, I tell you, we do this quite a bit now for these critical areas like motor strip or brainstem that have received previous radiosurgery. Now, this is just an example of a patient with a failure of these 2 breast metastases, if you can believe it, that were treated with single fraction radiosurgery, had some growth. The surgeon was going in anyway, so took out both. And now we're left with 2 cavities, both had viable tumor. So what am I going to do here? Well, that area is seen single fraction radiosurgery. Well, I'm not going to give single fraction radiosurgery again. Again, the risk of radiation necrosis. I'm going to give hypofractionated radiation. And at that time, again, I was using mainly Linac. And then you retreated both cavities simultaneously. You have to watch the bridge doses when you're dealing with close targets. And we at least try and break up the prescription plus, the close isodose lines. In this case, we couldn't break up the 2375 Sonny Gray isodose line, but we were able to keep the 25s broken. And again, deliver hypofractionated radiosurgery to this area. And because the cumulative target volume is large and we're dealing with previous radiosurgery, in this situation, I gave 25. I'd like to try and give 27.5 as much as I can, but you have to respect some of the BMC 30 in our experience here. And that really guides us when we need to dose de-escalate. Just in terms of another example of a patient who, again, benefited from cavity radiation and had a failure. So in this case, what you can see is a large lesion, had surgery. You can see the postoperative cavity, had 30 gray and 5 fractions in 2016. Lo and behold, had tumor recurrence. And then I gave 25 and 5 in 2017. Here's a patient in 2019 and 2020. Now, so the principle of reirradiation is either you drop the total dose and keep the same number of fractions, or you increase the total dose and try and escalate the BD, or you do both. In our experience, we try and keep it to 5 fraction approach, but de-escalate the total dose when we're reirradiating. Now, just to end off some unique situations that I've been doing, and this really requires a dedicated brain radiosurgery instrument. Whatever the technology is, you want to deal with something that you're really dealing with no margin and no room for error. And this is a patient with an ependymoma that had been treated in the past with fractionated radiation. And that dose was 54 and 30. And she failed there. And it's nodule pushing on the brainstem. And you say to yourself, well, what am I going to do here? This is not surgery. Am I going to re-irradiate? There's no drugs for this. I'm going to re-irradiate, but I'm going to use my brain radiosurgery instrument, but I'm going to fractionate. I mean, I'm a radiation oncologist. We understand the concepts of fully fractionated radiation and the potential benefits, but our aim here is safety first. So I'm going to give this person 45 and 25, but I'm going to maximize the heterogeneity by using my technology in my center as the icon, and I'm going to blast the internal component of it, but I'm going to keep that isodose lines as tight as possible and minimize the exposure to the brainstem. And this patient now is 3 years out, completely controlled with no radiation necrosis. And this is another example here of a patient with a pituitary adenoma that was radiated 10 years ago in the US, 54 and 30. And I approached it the same way. And I've got the chiasm there, and I've got residual functional pituitary gland there. And I said, well, look, let's do it. Let's apply the same principles, give 50.4 and 28, use the dose distribution by prescribing to the 50%, blasting it in the middle, and trying to preserve as best as possible the optic chiasm, most predominantly, but also the normal pituitary gland and the stalk. And she's now 3 years out, and again has had tumor response perfectly well with preserved vision and pituitary function. And this is just some of the paradigm that we're going to approach to challenge those norms, and why radiation oncologists are very important in this treatment paradigm, because this is something that a radiation oncologist would think about. And even though we warn her about blindness, you have a lot of options now with novel technologies that you can do things like this. And these are things that we would never do before. Now, I will caution you that when we do these re-irradiations, in particular in the base of skull, they do cause a lot of fatigue and tiredness for patients, but they get over it. Sometimes it takes a few months, but I've been doing this and salvaging cases that have been felt to be unsalvageable. So I think there's a lot for us to learn. So in conclusion, I would say that hypofractionated radiosurgery is here to stay and will only grow as the technology is basically permitting it. We have to be careful in hypofractionated radiosurgery for small targets less than 2 centimeters, as the standard of care is still single fraction. And this is more convenient for patients. And when you do it, we like to use a specialized unit, or at least very specialized equipment if we're doing on an MLC LINAC. We need to consider the individual tumor and patient as many new opportunities to maximize local control are present and reduce the risk of radiation necrosis by hypofractionating. And as patients are lived longer, radiation necrosis is something that is going to be a major area of us to really hone down on optimal treatment strategies, because it's not only life-threatening, but now patients are living so long that this is becoming more and more of an issue, and it can really damage their overall oncologic trajectory in terms of options for therapy. Selection of technology is really dependent on your program, but the principle of radiosurgery is to keep the uncertainty margins as tight as possible and ensure that treatment is efficacious and also minimize radiation necrosis. This is what QA, margins, immobilization, and ensuring that you have a sufficient volume of cases is so critical to any radiosurgery program. And with that, I would like to say thank you, and thank you, John and Igor, and I'm going to stop sharing and I can take whatever questions.
Thank you, Arjun. And I don't know how well I'm going to be, what kind of job I'm going to do as a moderator right now, given that I'm at the Denver airport. But I want to thank you, Arjun, for an illuminating talk. I think you really described what I believe is state-of-the-art use of hypofractionation radiosurgery these days. And I'm going to, if I'm not making the background noise isn't too disturbing, and Mark, you can let me know, I will ask a few questions here that the audience has passed on to you, Arjun. So Mark Levivier asked, You didn't describe the use of pre-resection radiosurgery for brain mets, as some people have advocated as a tool for minimizing leptomeningeal disease. Is this something that you're doing, not doing? Do you have any thoughts about pre-resection of brain, about irradiating with stereotactic radiosurgery prior to resection of brain mets?
That's a great question. And I didn't get into it because it's not necessarily fractionated pre-op radiosurgery. It's mainly single fraction, but it's an extremely important point in terms of how the field is moving. So for large targets that you're going to operate it anyway, if you have the opportunity to do preoperative radiosurgery, I think it's a great idea. The current data is limited to single fraction radiosurgery experience. And the concept there is really to de-escalate. So you still respect the idea that you have to deliver a lower dose because the volume is high, and that's being questioned. And even in my own practice, I do it, but I give, say 18 gray to a 3 to 4 centimeter tumor as opposed to 15, which you would otherwise, because they're getting it cut out anyway. And so I think we have a lot to learn about preoperative radiosurgery in terms of dosing and safety. One of the issues lies that if you do de-escalate the dose and there's a residual, well, now what do? That residual is treated with a very low, sometimes 12 or 15 gray in a single fraction, and that residual is not going to be controlled with that. So you want to select your patients very well for pre-op SRS, and hopefully those where you know that you're going to get a gross total resection. Now, typically the surgery should be done also within 24 to 48 hours. So if you're going to blast with a high dose of single fraction radiosurgery that you know is toxic otherwise, but you're doing it preoperatively, get it cut out within 1 or 2 days, as we don't know if adverse effects could happen very shortly after. Now, there are some groups, and I believe in Duke, that are advocating for the concept of preoperative fractionated or hypofractionated radiosurgery. So deliver 3 fractions times or whatever, and then cutting it out. And
for the record, Stanford is on that list too.
They are as well. Yeah, it's fine. It's the same principle, and it may be better for those tumors where you're not expecting necessarily a gross total resection, so you still maintain an escalated dose to the residual. I just don't think we know, and it might be okay. You're just delaying things. So if I have a chance, I just do single fraction radiosurgery and then get it cut out. But I think the field is evolving.
Someone asked about margins. So for an intact lesion or brain met, are you using any margins? So especially they comment about LINAC radiosurgery, where maybe the accuracy is a little less than you might want to accomplish with a dedicated instrument.
Right, excellent question. And so if you're going to use it, it all depends on the margins. Is dependent on the technology. Okay, so if you're using an MLC and a mask and a robotic couch top, and it's not necessarily a stereotactic radiosurgery dedicated machine, say like the CyberKnife, the Icon, the Zap, then you apply margin, and that's the principle. And typically, and we've done the analysis, you need about a 2 millimeter margin for PTV. Now, if you're using more rigid head immobilization, I think you can get down to 1 millimeter without any problem. But that's the concept of PTV. Now, when you talk about frame-based radiosurgery, then you can apply no margin. Some of the issues lie in frameless but dedicated units like the Icon or the CyberKnife. I don't know the data about the Zap, maybe John can comment, but there you're talking about not rigid immobilization of the head, and you should use some degree of PTV. So, and just to comment on my technology with the Icon, we use a 0.5 millimeter radially, 1 millimeter craniocaudally as a PTV now, as we can apply the margins, because when we do hypofractionated radiosurgery and frameless technique. John, do you want to comment?
I'll give a shout out to frameless. I'll give a comment to shout out to frameless radiosurgery, and I think those of us who've used it in functional cases have utter confidence in a dedicated instrument's ability to hit the target. We use no margin, and I can understand why we would use margin for a very large lesion where it's hard to define the post resection, where it may not be clear where the exact margin of tumor is, but generally we look at these things as no margin. But speaking of margin, and this is kind of a broader topic and it's peripheral to what you've discussed, but hyperfractionation is in some ways a general principle. And what do you think about its application for treating primary brain tumor, especially GBM?
Okay, so I would say, it's fascinating. And the Stanford data that really looked at a relatively smaller GBMs, but using 5 fractions radiosurgery, and they did this dose escalated study with primary GBM, I think is fascinating. And I think it is the way that it will go, not necessarily the dose, but the idea of CTV reduction. And so now we're not talking PTV, we're talking CTV. And so the idea of using a 5 millimeter margin plus or minus at-risk flare, and then delivering in a more convenient fractionation schedule like 5 fractions is wonderful. Now, what I took from that is not necessarily the 5 fractions, although I love it, is the concept of margin reduction. The caution and why we are moving towards on study a 5 millimeter CTV plus at-risk flare is we're using adaptive radiotherapy and we're using MR guidance, but we're keeping the 6 weeks because a lot of trials may exclude the patient for future drug studies if they weren't treated necessarily with the standard kind of Stupp type regimen. So we're cautious on that end. But I think if once that kind of dissipates, and I think I would love to do small GBMs like the Stanford approach. And the Memorial Sloan Kettering had published their data in clinical cancer research several years ago with hypofracture radiosurgery for larger tumors, but with the use of Avastin. And so they're controlling that radiation necrosis. So you have to be careful because of the necrosis risk, and you don't want to hurt the patient. And those are well-selected patients. So it's not necessarily widely applicable for most glioblastoma patients. And that's why we're using 60 gray and 30 fractions with Timidol, but a 5 millimeter margin using MR adaptive radiotherapy.
Okay, well, it's a wild frontier, and I'd like to think we're not locked into 7 or 8 weeks of radiotherapy forever, because that's what existing clinical trials mandate to enroll patients. We'll see. But I'm going to ask one last question, and someone asked, what are the control rates for multiple brain mets with a specific fractionation regimen of 30 gray and 5 fractions? And yes, it is, but someone asked, is it histology dependent? Care to jump on that question for us?
Yeah, sure. I'll take it in 2 ways. First of all, it doesn't matter how many mets you treat, each one is independent. I think we've learned that from the data. So I wouldn't necessarily quote a lower local control rate for a met if it was solitary or there were 5 being treated. The second part of the question, John, you want to just remind me what that was?
Really want to know about the control rate specifically for 30 gray and 5 fractions.
Yeah. Okay. Our control rate is around 80%.
Pretty much the question.
Yeah. The second part of it was histology dependency. So certainly when we have a colon or melanoma, then we'll escalate despite our volumetric parameters, because we know they're hard to control. In particular, GI primaries. There, if you treat with 25 and 5, I don't think you're doing the patient a service. You really need to escalate. So that's when I try and push as hard as I can, 32.5 or 35 and 5 for GI malignancies that have metastasized to the brain. Probably also for melanoma. Renal cell is somewhat heterogeneous, but certainly the classic tumors that are radio-resistant, sarcoma, melanoma, GI primaries, those are the ones that you really want to think about maybe taking more risk of radiation necrosis to control the tumor.
Okay, maybe one last question. So I don't think we're going to talk about flash radiotherapy, but someone suggested that somehow the opposite of what you're doing might be flash radiotherapy. It's a way to think about it, but I'm not sure when we're going to be able to do anything like the cases you've just alluded to. But another question is, what about hypofractionation for other lesions besides GBM, benign tumors, for example? Any comment on that?
Sure, happy to. I mean, I certainly have moved away for vestibular schwannoma from single fraction. I mean, if they're small and beautiful and ideal, yeah, sure, we'll do it. Of course, we always offer it. But you know, the use of 25 and 5 with a dedicated instrument with minimal to no margin is excellent treatment, and it may bear out. It doesn't seem like it that it's resulting in better hearing preservation rates, but the concept is there, and it may improve the safety profile, in particular for larger vestibular schwannoma, because you know, once you start talking about over 2.5 to 3 centimeters, you know, the risk of pseudoprogression is not insignificant, and that might be one benefit to hypofractionated radiosurgery, because pseudoprogression can be symptomatic and disabling for patients with schwannoma, and it can happen 30 to 40, 50% of the time, and so that's one area that we like. So I don't necessarily do it for hearing preservation. It may reduce some of the risk associated with cranial nerve 5 dysfunction for tumors that are touching or very close to the trigeminal nerve. And so that's an idea. So basically, at the end of the day, I mean, we have really moved to 5 fractions for vestibular schwannoma. And then for meningiomas and other benign tumors, the concept is there. And the safety profile may be better. And I would say, in particular for parasagittal meningiomas, because you know there's a lot of edema that arises, you know, we like the idea of 5 fractions, but we give the option to the patient.
Well, some of those ideas are heretical to many people in the community, but I tend to subscribe to some of them myself. So anyway, Arjun, I want to thank you for a very thorough and interesting and enlightening discussion and walk through the world of hypofractionated radiosurgery these days. And I liked your shout out to dedicated instruments, because I too believe that the future is going to be increasingly not just radiosurgery, but the best possible radiosurgery for each and every patient. So again, thank you very much. And I will thank everybody in the audience for joining us on our talk today. And I look forward to seeing you in future webinars. Thank you, Arjun. Thank you.
Thank you. Thank you, everyone.
Bye-bye.